You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is August 18th, 2023. Our topic today is urticaria and angioedema. Our presenter is Dr. Jonathan Bernstein. He is the current AAAAI president and professor of clinical medicine in the Department of Medicine, Division of Rheumatology, Allergy, and Immunology at the University of Cincinnati Medical Center in Cincinnati, Ohio. We're sorry, Dr. Miller is currently doing interviews, which is why he's not able to be here, but I'm Tal, I'm one of the second-year fellows. So we'll go ahead and get started with Conferences Online Allergy. Today we have Dr. Jonathan Bernstein. He is a professor of clinical medicine in the Department of Internal Medicine, Division of Rheumatology, Allergy, and Immunology at the University of Cincinnati Medical Center, and he's also a partner of the Bernstein Allergy Group and Clinical Research Center. He received his MD from the University of Cincinnati College of Medicine and completed his residency in internal medicine at the Cleveland Clinic, and he did his allergy clinical immunology training at Northwestern University. His spectrum of research interests includes allergic skin diseases, notably chronic urticaria, angioedema, atopic dermatitis, mast cell disorders, chronic cough, asthma, and chronic rhinosinusitis. He is the current president of the AAAAI and a member of the Joint Task Force Guideline Committee, the WAO Board of Directors and Interasthma Board of Directors, GINA Advocacy Council, and HAEA Organization Medical Advisory Board. Dr. Bernstein is also the recipient of the Distinguished Clinician Awards from the AAAAI and WAO. He is an author of 440 peer-reviewed articles, over 40 book chapters, and is the editor of 5 books pertaining to asthma, rhinitis, and immunodeficiency. So thanks for coming and chatting with us today.
My pleasure. Thank you for having me. And so I'm going to, over the next 45 minutes, I guess I have, to talk about urticaria and angioedema. Try to, everyone see that now?
Yes,
Hello?
we can see that. Yeah.
Okay, very good. Okay, thank you. All right, so we'll talk about urticaria and angioedema and how it relates to the current practice parameters. These are some of my conflicts of interest. And again, these are the objectives. We're going to go over the pathogenesis of urticaria as chronic spontaneous urticaria, determine its burden of illness, define management based on guidelines, and determine current best treatments for CSU. And we'll start with a case study of a young woman who presents with recurrent hives associated with angioedema that has been persistent for the past 6 months. And during this time, she's been treated by her doctor with short courses of oral corticosteroids that resolve the hives spontaneously or temporarily. She previously had hives in 2013, 2014 that resolved spontaneously after treatment with corticosteroids. Her current episodes have been much more severe, involving most of her body, and the itch is very severe on a scale from 1 to 10 of 10. So hives actually have some systemic symptoms associated with chills and joint aching. They've been disruptive to her sleep, leisure activities, and work. And she notes that the skin welts when she scratches or when she gets anxious or upset. There's no prior laboratory testing by her primary care doctor, and she also notes that her hives seem to get particularly worse a few days before her menstrual cycle begins and improves, but don't completely resolve midway through the cycle. So just from this case study, you can see there's several clues that one should be honing in on, and I'll just review those for you. But in terms of the case, the number one, obviously they're chronic because they're lasting longer than 6 weeks. She has a more severe form of hives because she has associated angioedema with the hives. She's been getting recurrent courses of corticosteroids, which is not how we want to treat hives because there's cumulative side effects when you keep taking oral corticosteroids, and the short and long-term side effects. It's obviously very severe, and there are some associated chills and joint aching, which can be seen in chronic urticaria, but this can often cause people to be misled and think, oh, it's not hives, it's something else systemically. And of course, it's very impactful, disruptive to life in general. And the other thing important, she notes that when she gets hives, when she scratches or gets anxious or upset, which would kind of hone you in, does this patient have dermatographia? Does she have evidence of cholinergic urticaria, which can cause when the body temperature heats up, and as it starts to cool down, hives can come out. The last note is that the hives occur perimenstrually, which seems to be like a cyclic type of hypersensitivity. And one of the differential diagnostic things to think about here is progesterone hypersensitivity. So when you think about chronic urticaria, the onset is typically between the 20 and 40 years of age, but it can occur at any age, and it depends on the population study. In some countries, they found that children have a higher prevalence than adults. So, we need more epidemiology data on chronic urticaria. It can last anywhere from 1 year up to 10 years. The median duration is 5 years. When you have evidence of an inducible hive, as this patient does, she probably might have dermatographia, she might have cholinergic urticaria. There's a more protracted and more severe course of disease, less responsive to conventional therapies. On average, 33 to 67% of hives exhibit wheals with angioedema. And this diagram, the pie diagram, we see 40% is the average or so, and about 40% have wheals only, and up to 20% have isolated angioedema, which most of these patients have histaminergic angioedema, although when people present with isolated angioedema, the differential diagnosis is a little bit different, which we'll talk about. Whoop, hello, I think I have what happened here? Hold on for 1 second. This is the, uh-oh, what did I do? Did I do something? I think I clicked something wrong here. Sorry about that. I got to go back in and do this again. You know, one of the things they don't give you is a degree in technology. Okay. Do you see it now?
Yes.
Okay. So this is a slide which shows the classification, triggers, and prevalence of inducible hives. And just to, you know, we used to call this physical urticaria, but we've kind of made it the chronic inducible urticaria. And under that category, there are several physical stimuli that can induce hives, such as scratching the skin, also known as dermatographia, cold-induced urticaria, delayed pressure where there's prolonged pressure at a site, and solar urticaria, heat contact, vibratory, and then inducible hives, which is typically due to like either cholinergic, could be a contact, or aquagenic. Less commonly, adrenergic urticaria has been described as well, but active or passive body warming is typically what we see with cholinergic urticaria. People can get emotional though as well and very upset. That can result in body temperature changes as well. And so these are, again, the epidemiology is, the prevalence is not well known. Probably the most characterized is symptomatic dermatographia and cold-induced urticaria, and also possibly cholinergic. But these other ones are very rare, and typically we recommend provocation to diagnose these things. People use a tongue blade or a applicator, a blunt edge of an applicator to scratch the forearm. There's something called a Frick test, which can be used that has different lengths of prongs that you scratch along the forearm, and that will result in different lines. And if you, depending on the line that welts up, will determine the severity of it. So this has been used in clinical trials to look at improvement in response to treatment, because if the shortest prong will give the lightest line, and that would, if they welt up, indicates very, very severe symptomatic dermatographia, and typically that shifts towards the longer prong, which is less severe. Hope that makes sense. And then, of course, cold-induced urticaria can be done with an ice cube challenge, where you take a bag of ice and put it on the forearm for 5 to 10 minutes, and a welt should occur, but it's not very quantitative or qualitative. So there's something called a temp test, where you can lie the arm on this machine and it cools down to 4 degrees C, and you can see the degree of cold-induced urticaria after patients had their arm on this for like 10 minutes or so. But there are other ways of doing these provocation testing. Cholinergic urticaria requires exercise ergometry. You get on a bike and you exercise, and then as they cool down, you can see visible hives emerge and so forth. Unfortunately, most clinicians don't do these provocation tests, and it is important, though, at least for the symptomatic dermatography and the cold-induced urticaria. And when possible, cholinergic, you could have them run around your office and come back. You know, that might help too, but getting their body temperature hot. People don't have the temp test because it's several $1,000s to purchase this, so it's not clinically practical as of yet. This is the pathogenesis of CSU, and I think it's important to know that, of course, probably it's very similar in many ways. There's shared pathways with other inflammatory skin disorders, and the epithelial barrier is very important, just like it is for other inflammatory diseases like atopic dermatitis, and that there are different triggers that can cause disruption of the epithelium, whether it's an unknown allergen, which again, we don't find specific causes like food allergy or drug allergy, or of course not at all aeroallergens are not a cause of chronic urticaria, but there can be disruption from physical stimuli as well that cause the release of alarmins from epithelial cells that can activate T cells and result in different T cell, some of these are innate lymphoid cell type 1 versus 2 versus 3, but typically most of these are important for driving innate lymphoid cell type 2, but these can also activate mast cells that will release mediators, but there's a whole array of other pathways involved and other effector cells that have other roles in the process. So it's quite complex, and we still don't understand a lot of these different pathways for causing the pathogenesis, but everything is targeting the mast cells now in terms of whether we look at c-KIT receptors, these mast-related gene peptide receptors, there's cyclic receptors on mast cells, complement receptors, of course, IgE receptors, and so forth. So all these things can potentially activate mast cells, but why do they occur in some patients and not others? It's not entirely clear. And I think it's also important to realize that there are neurogenic pathways involved as well that can interface with mast cells and other effector cells that can, these nerves can depolarize and release neuropeptides that can activate mast cells, as well as the cytokines released from mast cells can activate these nerve fibers and further worsening the manifestations of hives. So it's quite a complex process, and there's still a lot we don't understand about the pathogenesis. Now, I do want to insert here a little bit about angioedema, because there are a number of times when patients present with isolated angioedema, and of course you all are trained to recognize hereditary angioedema, but this only is seen in about 4,000 people in the United States, so it's a pretty low prevalence. So in these cases you want to get a C4 level just to screen if there's no defined family history and no high suspicion for a bradykinin-mediated form of angioedema, especially if they respond to antihistamines or steroids. It's unlikely they have these conditions. So you don't need to go order a C1 inhibitor function or antigen level. You just get a C4 level as a screening test, okay? It's good that you understand what to order, but you don't have to, order all of these things at once. They're expensive tests, and if a C4 level comes back low, obviously this could be, especially in the absence of a family history, there could be a de novo mutation, which is seen in about 25% of cases, and then you would order the function and the antigen, and also a C1q to show whether or not these patients have a hereditary type 1, type 2 angioedema versus acquired angioedema. Again, acquired is even much less common. 1 in 100,000, 1 in 150,000 patients have this condition. Recognize that C4 is not perfect. It could be normal in somebody who has HAE, and if you have a high suspicion, you should repeat it or get additional testing. And C1q can be normal in a patient with acquired angioedema as well, and low in a patient with hereditary. So the definitive test, if you're confused which one it is to get a genetic test to do a mutate, to look for a mutation in the SERPING1 gene to make sure there's no genetic mutation, which you would not see with acquired, but you would see with hereditary alpha tryptase, with hereditary angioedema. I got mast cells on my mind too. So anyway, so this is a important caveat. You don't need to order every test, but get a C4 if they have isolated angioedema. In this patient, she's got hives with angioedema, so you don't need to necessarily order this test. It's really not appropriate. Just to show you that, in contrast to urticaria, the pathogenesis for HA is quite different. The contact activation system is where most of the activity is in terms of the pre-kallikrein is cleaves kallikrein to which has a direct effect on cleaving high molecular weight kininogen to form increased bradykinin that binds the bradykinin 2 receptors, and this is what leads to vasodilation with vascular leakage and edema. Of course, there are many checkpoints where C1 inhibitor has a relevant role. It can regulate complement pathways. It also regulates the MASP2 pathway specifically, or the MASP1 pathway. Well, it can regulate both MASP1 and MASP2, but MASP1 has a direct effect on increasing BK2 receptors in the endothelium. So if you don't have C1 inhibitor, you have more BK2 receptors, and this could result in more severe edema. And similarly, it also has an effect on the plasminogen pathway, which may explain why tranexamic acid works in some of these cases. This is what we used to use before we had, alpha epsilon aminocaproic acid and tranexamic acid, which are antifibrinolytic agents. This is what we used to use before we had novel therapies. And this may be relevant in patients who have the normal complement pathway, and we recently published a series of cases showing tranexamic acid also works very well in acquired angioedema. That being said, the activity is here, and the treatments that have been developed, like C1 inhibitor replacement therapy, would actually help prevent the breakdown of high molecular weight kininogen to form bradykinin, and again, that's very important. There's also kallikrein inhibitors that have been developed. Lanadelumab is a prophylactic agent that will block kallikrein, so you can't cleave high molecular weight kininogen and form bradykinin. There's other agents. There's now an oral kallikrein agent that can do the same thing, and there's also some on-demand oral kallikrein inhibitors that are currently under investigation for on-demand treatment. Of course, the most commonly used on-demand treatment is icatibant, which blocks BK2 receptors. There's also an oral therapy that is being developed on a BK2 receptor for acute as well as prophylactic treatment. So we have a lot of interesting therapies on the horizon. We're working to either block pre-kallikrein or knock it out by CRISPR technology. There's also some genetic studies that are looking at inserting the C1 inhibitor gene into liver cells of patients with HAE so that patients can make their own C1 inhibitor. And so on. So there's a lot of interesting stuff going on in this area. In the last 10 to 15 years, we've made incredible progress in treatment for these patients. But the patient I presented today does not have HAE based on her history, but I did want to just kind of mention this because a lot of times we see a lot of patients coming through with unnecessary testing because it's great that people are thinking about it, but we want to think about it in the proper history, the proper context of the patient's history. So this is her past medical history. She had no other chronic health issues, no relation to medications, foods, underlying medical problems. Her family history is unremarkable. She was taking cetirizine 10 milligrams a day, famotidine 20 milligrams twice a day. She was on high-dose steroid taper, and she was also using a lot of Benadryl, but was getting a lot of sedation. She was single, non-smoker, social drinker, works as a receptionist. She notes the hives were very disruptive, as I mentioned, and also affects her intimacy with her partner, which has been reported in urticaria. Now, I'd like to point you to an article from the Journal of Allergy in 1954 by several thought leaders at the time. Sheldon, Ken Matthews, Lovell were all very prominent allergists, and they wrote this editorial, The Vexing Urticaria Problem Present, comments of etiology and management. They said, although urticaria often is a rather transient and trivial illness, which scarcely merits very serious medical attention, some patients with severe chronic recurrent hives are indeed most uncomfortable and appreciative of whatever help one can give them. Well, I think that this underestimates and possibly trivializes the severity of hives that patients are dealing with, and this obviously brings us to what is the burden of illness related to hives. And this is one study which looked at this specifically, real world evidence. It was called the Assure CSU study. And basically there are 637 adults with confirmed CSU diagnosis who had been symptomatic for 3 days or longer for over 12 months. They were enrolled in multiple sites in 7 countries, and there was a retrospective medical chart and cross-sectional study, patient-reported data study. It was the information was collected and analyzed, and they found that 50% of patients had moderate to severe disease activity while on treatment, and they still had moderate to severe itching and hives over 4 days a week. And when they looked at quality of life and disease burden, as measured by these validated instruments, it was the most commonly affected domain was physical discomfort. But as the severity increased based on UAS7, the impact on quality of life also increased. When we think about the one important aspect, it's absenteeism and work impairment. You see that patients have significant, as the severity goes up, there's a significant greater number of missed days from work. Again, number of days absence in a 4-week cycle goes up, and also the impairment at work goes up as well over this time period. Again, this translates into significant costs associated with absenteeism and presenteeism when patients are there, but they still have, but they just aren't efficient in their workplace and they aren't very effective. The cost, again, when you look at the cost, it's estimated to be $9,000 per year, mean total healthcare cost for patients with CSU. So again, even though we don't see as many hospitalizations, the costs are quite high due to outpatient services associated with urticaria, and of course medications and so forth. And it actually approaches that of the same cost that was spent annually on hypertension and diabetes. So it's more than a trivial illness, and it demands that patients are diagnosed properly and treated properly. This patient had a UAS7, which is the Urticaria Activity Score 7 of 32. The Urticaria Control Test was 0. It's important that we start using these patient-reported outcome measures that are validated in our clinical practice. The simplest one to use is the Urticaria Control Test. She had no evidence of dermatographism, even though she actually said when she scratched they got worse. And this is because patients with hives can urticate, and so but it doesn't automatically mean they have dermatographism. The classic presentation of dermatographism, patients present with a lot of itching, and they get welts, and so they come in and they say they have welts. You always have to determine what comes first, the itch or the welt. And a lot of times they'll be able to tell you it's the itch. I itch, I scratch, and I get welts, and then you can reproduce dermatographism by physical stimulus. Eliminatory laboratory assessment, CBC, SED rate, CRP, TSH were all normal. So these are the 3 guidelines that are out, the most recent being the international guidelines that was published last year. The guidelines that we developed through the Joint Task Force were last updated in 2014. We're currently going through an update currently, so we hope to have by the end of next year another updated guideline, which will be a grade methodology guideline for chronic urticaria, acute and chronic urticaria, and these are currently underway. We look at the diagnostic workup for urticaria. Obviously, you have to have a differential diagnosis. In this patient, hives are very high, but one may be confused because she has systemic symptoms. Could this be an urticaria vasculitis? Could this be something else systemically going on? Of course, you can exclude acute urticaria because it's been going on for over 6 months. So it's definitely chronic urticaria. The cut point is 6 weeks, less than 6 weeks. Acute, greater than 6 weeks, a chronic urticaria. Her history suggests chronic inducible urticaria. She didn't have dermatographia, but she certainly could still have cholinergic urticaria. And then again, the question is it chronic spontaneous? And by her history, it is. We rule out other types of systemic inflammatory disease. She had some screening tests which showed that her CBC, her SED rate, her thyroid, her CRP were all normal. There's nothing else in her history to suggest otherwise. So one wants to quantify disease activity, quality of impairment, disease control, which was done. She has no control, and it's significantly impacting her health. We did not use a quality of life questionnaire in this patient, and it's something that we should do. But again, in clinical practice, it can be kind of burdensome to contain all of these questionnaires and put these on an electronic medical record system, but certainly that is something which I think would be very useful to have these types of patient-reported outcome tools. Again, the UAS7 is based on severity of itch and the number of hives. It's a recall period's 24 hours. It's administered daily for 7 days, primarily used in clinical trials still. The angioedema activity score, also recall period 24 days, administered over 7 days. Again, measures swelling episodes, time of day, severity of physical discomfort and swelling, impact of swelling on daily activities and appearance and overall severity. The easiest one to use is the urticaria control test, which is a recall period of 4 weeks. And it does measure the extent of suffering from physical symptoms and also the extent which quality of life was affected, how often treatment was not enough to control symptoms, as well as the overall control of urticaria. The chronic urticaria disease activity score, which is used in clinical trials, this is an example where this is what it looks like. It's on a scale from 0 to 3. The wheels, no wheels is 0, no pruritus 0, less than 20 wheels per 24 hours is a 1. Present but not annoying or troublesome is the pruritus, and then as you get to higher levels greater than 50 wheels, severe pruritus, this is a 3. So again, this is something we aren't using as often in the clinical practice because patients have to do it every day. Now there is an app called the Cruise app, which is you can download online for free and have patients use this app, and they can rate their hives using this score over time, so you can get some objective evidence of how they're doing at baseline and in response to treatment over time. So I think that that's a really useful app that is now available for patients to use. It's called CRUSE. There's other patient-reported outcome measures that are advocated through the guidelines, the quality of life questionnaire, the angioedema quality of life. There's the dermatology life quality index is used in clinical studies, as is the European quality of life 5-dimension level. They all measure very similar things. They have different recall periods, and they are helpful, but again, getting them to be used in clinical practice is difficult. The Cruise app should have the ability to measure quality of life, to some aspects of quality of life on this app. But why is it important? Well, here you can see that when you look at quality of life, the psychological impact of chronic urticaria, you see that using these instruments, that a number of these factors, a number of these domains, like sleep problems, embarrassment, looks, mood, fear, concentration, anxiety, depression, they all increase as the severity of hives increases. So this is quantitatively quite significant when you look at the number of the percent of patients that respond to this and what impact it has on them. This was from the ASSURE study that was like over 670 patients. So the treatment recommendations, we wanted to get off prednisone. We maximized her treatment according to step 1 therapy of the 2022 guidelines, which was to go up to 4 times the recommended dose of antihistamine. We kept her on 1 dose of antihistamine. We don't one type of antihistamine. You don't need to mix and match antihistamines. Our previous guidelines in 2014, the U.S. guideline says, well, you could use fexofenadine in the morning and cetirizine at night because some people get sleepy. The most recent guideline says stick to one type of antihistamine, but again, in some cases, patients may require something less sedating, and so rather than using cetirizine, you use fexofenadine, 180 milligrams, 2 pills twice a day. This is comparing the step 1 therapies from the 2018 international guideline and the 2014 US guidelines, and you can see they both advocate monotherapy with second generation antihistamines, but step 2 recommended only going up 4 times, whereas the step 2 for the US guidelines said you could dose advance. You could add another second generation histamine, you could add an H2 antagonist, leukotriene modifying agents, or a first generation at bedtime. Now this is going to change based on some evidence-based medicine that will probably make some definite changes. But you could see there was greater latitude in using some of these other secondary agents. These did not make the grade for the international guidelines, and of course there's a lot of issues with sedation and possibly cognitive changes in patients taking first generation antihistamines for long periods of time, which would make these somewhat relatively contraindicated. So follow-up, she responded to the higher dose. Her UCT score is now 6, still not controlled. She still has a high UAS 7, uncomfortable daily hives. Her hives are still interfering with work, sleep, interpersonal activities, and she has now hives 50% of her body. So what's the next step? She's got refractory symptoms despite maximum doses of non-sedating antihistamines. Should we do additional lab testing? And based on her history, should we identify tests that might predict response or poor response to next step treatments, which in this case would be omalizumab. And we'll talk about that in a moment. She also gave some perimenstrual history, and should we talk about progesterone hypersensitivity? Should we order progesterone-specific IgE? Would a skin biopsy at this time be helpful to see what type of infiltrate she has? Classic hives typically sees lymphocytes with eosinophils, whereas in more mixed infiltrates with eosinophils and neutrophils, which suggests possibly a chronic autoimmune urticaria phenotype. So we are hesitant to tell people to go order testing randomly due to this study that was done at the Cleveland Clinic by David Lang and his group, where they looked at whether or not extensive diagnostic testing should be performed, and they found that only 1 out of 356 patients benefited from testing. They did a number of tests, but they found that these tests really had no change, really had no effect on how patients were managed, except one patient improved with, who was hypothyroidism, improved to a slightly higher dose of thyroxine. Other than that, there was no improvement in management. So the guidelines recommend not ordering a lot of testing unless there's something in the history that makes you suspicious where there is a reason to do that. So with clinical suspicion, one could do that. And now we're at the age where we have to ask the question, are there biomarkers that may be predictive of treatment response? And of course, we know a long time, it's been described by Malcolm Greaves about autoantibodies and their role in possible chronic urticaria. Most patients, up to 50% of patients, might have chronic autoimmune urticaria where they make IgG antibodies to the alpha subunit of Fc epsilon receptor 1, and to a lesser extent to the alpha subunit of IgE. This is, one can elicit these responses using autologous serum skin testing or through a blood assay. You can get a chronic urticaria index, which is now readily available, or you can do an autologous serum skin test, which you inject, 0.05 ml underneath the skin, and you can see a wheal and flare within 15 minutes. That is consistent with autoantibody. The problem with this test is that there's a lot of false positives, and so it's not very specific. So I think we favor the serum test over the skin test these days. So people have looked at biomarkers, and they found that there are certain characteristics and certain tests that correlate with patients being responsive to antihistamines or not responsive. In our case, the patient had angioedema, and she was. They found that people who have associated angioedema tend to be less responsive to antihistamines. She also had inducible hives, possibly cholinergic urticaria, was less responsive to antihistamines. But they've also found patients with autologous serum skin tests or basopenia, high CRPs, and even higher baseline UAS scores as being less responsive to antihistamines. In our case, our patient had very high baseline UAS scores. So do these measure up, and are these useful in clinical practice? And I think we don't have definitive answers, but there is good bit of that data to support using some of these biomarkers for predicting response to antihistamines or unresponsiveness to antihistamines. So people also looked at basophil and eosinophilic phenotypes, and it's been shown that basophil responders to anti-Ig stimulation compared to non-responders have longer duration of disease. They have higher frequency of ED admissions, higher itch severity, but there's no difference in oral corticosteroid response. There is increased work loss, and there's also poor quality of life. So basopenic histamine release non-responders exhibit poor response to omalizumab, independent of these anti-FcεRI receptor antibodies. So this may be also a marker of poor response to omalizumab. And similarly, they found that patients who have very low peripheral blood eosinophils may also have a poor response to omalizumab. So a CBC with DIF, looking at their basophils and their eosinophils at baseline might be useful in predicting a response to omalizumab. This is a table which basically shows that there are certain biomarkers that might confer resistance, such as the histamine releasing assays or autologous skin tests. Very low total Ig levels, less than 40, tend to be less responsive to omalizumab and so forth. So I think that we're starting to see that these biomarkers may be relevant in helping us decide where do we go next with this patient. So I'm not going to, we aren't at the point yet where we can say that these are incorporated into guidelines because they haven't been definitively proven, but there's more work to be done to determine can we use these biomarkers or other undefined, other yet to be defined biomarkers to predict algorithmic treatment risk in these patients with chronic urticaria. People have also looked at histology, and again, patients who have high neutrophil counts and lower eosinophil counts tend to be poor responders to treatment versus patients who have more lymphocytes and eosinophils. They tend to have better response to antihistamines and to treatment, better treatment responses. Patients who have mixed infiltrates, again, which is more consistent with chronic autoimmune urticaria, these types of profiles tend not to be as responsive to medication. So this is a case of mixed lymphocytes with eosinophils and neutrophils, which might be useful in determining will this patient respond to a drug like omalizumab or not. This is a step-down option. This is in the more recent article on Nature Review by Colcure et al., and this is showing that how one could step up and step down with treatment. But here you see that using markers, high C-reactive protein, high D dimers might predict poor response to second-generation antihistamines, whereas biomarkers like low baseline IgE, high basophil releasing assays like CU index or low expression, baseline expression of the FcεRI on basophils might be poor responding to omalizumab, whereas good response to cyclosporin would be these patients, positive basophil histamine releasing assays and such. So again, we're not quite there yet, but this is the future that could allow us to understand how to step up and step down with treatment in these patients. This is comparing the guidelines where after from 2018, 2014, we see that whereas the U.S. guidelines is recommending advancement to more potent antihistamines like hydroxy and doxepine, it was recommended to go right from second-generation antihistamine to omalizumab based on evidence, and then depending on the response within 4 to 6 months, maybe go to cyclosporin. Here we just lumped everything together as an alternative: omalizumab, anti-inflammatory agents, immunosuppressants. But one has to recognize 2014 was right when omalizumab was approved for the treatment of urticaria. So this was right before it became approved, so we didn't have as much information. So I think these guidelines will change and are probably going to be more in line with the current international guidelines. But we'll see as our guidelines evolve. So why is there a need for alternative novel therapies? And this is showing a study from our group which showed the performance of CSV medications before the omalizumab era. You see that only 38% were completely controlled on combinations of first or second generation antihistamines and leukotriene modifying agents. And many of these patients required cyclosporin, and almost 20% required regular use or frequent use of corticosteroids. So again, not a very good track record using these existing therapies. Some have reported 40% or 50%, but this is in the ballpark of what we see with response to treatment. So this suggests a large percentage of patients we see probably have chronic autoimmune urticaria. These are the original studies that were done with for omalizumab for the treatment of chronic spontaneous urticaria, and we see that there was a dose response improvements, 300 milligrams dose versus 150, 75 in placebo. This led to the approval of 300, although 150 was also an option. But there's still a lot of issues pertaining to the use of omalizumab, again, administered subcutaneously, which is good, and it can also now be administered at home after the first 3 doses are given in the office. But there's still a risk of anaphylaxis. It requires patients to have an epinephrine injector, even though the more recent data shows that it is safe to administer at home if it's well tolerated after the first 2 doses. We don't know the treatment duration and how to step down over time. It's still unclear because patients still have, a lot of these patients that take this medication for many months and years, and of course, we need to have better direction on stepping up and stepping down on treatments. Again, are there biomarkers? We need to have better biomarkers that can be used to predict response, so patient selection is more tailored. And does the burden of disease warrant cost of biologics over time? And that's the big question that we see with a lot of disease processes. And I think in our case, we showed that there is significant impact, direct and indirect costs associated with urticaria. But does this have to be a lifelong therapy? That's a question. But omalizumab, 300 milligrams every 4 weeks was started. She was seen 2 months later, was still having hives and intermittent angioedema, although her UCT was now 12 and her urticaria activity score was 16. And so she had a partial response. And one has to ask the question, is a partial response good enough? And so what do? Do you stop omalizumab and start cyclosporin? You increase the dose of omalizumab or the frequency of dosing or both? Do you continue omalizumab and add other second-line agents like cyclosporin or other alternative therapies that have been advocated for the treatment of urticaria? But I want to just take a mention that cyclosporin is step 3 therapy for international guidelines, and it is an immunosuppressant which is capable of inhibiting multiple cytokines, and it does have an effect on nuclear factor kappa beta, which is important for producing these cytokines. It does have toxicity, so you need to monitor blood pressure, lipids, renal function, but their studies have shown that it does have a significant effect on reducing histamine release, and it also reduced the autologous serum skin test response, is what we used to use to see if patients have autoantibodies before we had good serologic tests in patients who are responsive, this test would actually go from a large wheel and flare to a lesser, to a smaller wheel and flare. So it has been recommended as step 4 for international and U.S. guidelines, and now with the modified guidelines, it's step 3. So we have this this condition called chronic spontaneous urticaria. It's got heterogeneous clinical symptoms and presentations. You know, the phenotypic characteristics, you can look at various characteristics, such as severity, the condition, triggers, biomarkers, response to treatment, and you know, trying to categorize these people like we have with asthma and other chronic disorders that we treat as urticaria endotypes is where we currently are. Are these patients antihistamine responsive? Do they have chronic inducible urticaria? Do they have something called type 1 autoallergy, type 2B autoimmunity? Are they neutrophilic? This is, and of course there are other phenotype and endotypes of it that may exist as well. And again, it's why I think it's important to characterize patients with urticaria to see, you know, are they one of these types of urticaria? And again, the type 1 autoallergy, these people typically have IG antibodies to like thyroid peroxidase or IL-24, other autoantibodies. They can respond to medicines like Xolair, but they have a slower response compared to patients who are antihistamine responsive. And then, of course, this type 2B autoimmunity is where patients have the autoantibodies directed against the IG receptor on mast cells. And of course, neutrophilic tend to be a totally different condition that don't respond very well and might respond better to things like dapsone or colchicine. I did mention progesterone hypersensitivity in this patient, and I guess this is just you know, something that has emerged. It's a type of catamenial anaphylaxis. Patients have heterogeneous skin lesions. Systemic reactions have been reported. Typically, they begin 3 to 10 days prior to menses onset and can persist throughout the menstrual cycle, but typically resolve a few days after menstruation begins. And it can be difficult to identify because of cyclical patterns in patients with irregular menstrual cycles. But there are assays now available that can measure specific IG through that are pretty good. It's difficult to measure with skin testing because it's not water soluble, and you have to suspend it in a lipid based, and so you can get a lot of false positive reactions. So it's still unclear whether, though, this condition, progesterone hypersensitivity, is an IG immune response, or is it a type 1? Is it an example of type 1A autoallergy? Because this is what we see with patients making IG antibodies to like thyroid, in patients with underlying thyroid disease, thyroid autoantibodies. So it's possible that this could be a type 1 autoallergy, and more work is needed in this area. So I just want to summarize chronic urticaria management. You know, you start off by assessing, you know, diagnosis. You want to exclude mimics, comorbid special populations, severity assessment, which we talked about, patient preferences, adverse events, looking at comorbid illnesses, and then you want to start treatment and treat comorbidities. We talked about the current treatments in the guidelines, but there are, of course, other treatments that might be necessary that, especially if these therapies aren't effective, we still need to better look at ways of differentiating the patients who are going to be more responsive to omalizumab versus less responsive, and where alternative therapies might be useful. And then looking at making decisions based on these objective patient-reported outcome measures, and then adjusting therapy, step up if inadequate control, change if adverse events occur, or step down if symptoms are controlled for 3 to 6 months. And I think this is important when you have patients on omalizumab, that after 6 months, if they're high free, if their UAS7 is equal to 0, we should start thinking about stepping down or off of omalizumab. There are a lot of promising drugs in the horizon that are being investigated that are interesting. There are drugs that block c-Kit that are being looked at in wild-type c-Kit. There are drugs that are directed towards this MASP-related gene peptide receptor. There are Siglec-8 and Siglec-6 compounds being developed currently. There have been a lot of treatments, though, looking at IL-4 receptor alpha, which is currently being decided whether it will be approved by the FDA for urticaria. It's currently before the FDA for possible approval. Omalizumab, of course, is effective. Ligelizumab was like the son of omalizumab. And unfortunately, although it was effective for the treatment of hives, it was no more effective than omalizumab and was abandoned. But there's a number of other drugs that were tested, these anti-IL-5 and IL-5 alphas, which we do have IL-5 receptors on mast cells, but the treatments have not been shown to be effective, which kind of suggests that, and this is also being seen in the eosinophilic esophagitis paradigm, where eosinophils are important effector cells that may be contributing to disease, but they're not the main effector disease, and that mast cells may be the primary effector cell in these different conditions. These are the potential molecular targets and therapeutic agents for CSU that are currently being investigated. And I mentioned some of these that are further along than others. The ones that are probably most further along are the BTK antagonist. Remibrutinib is in starting phase 3 trials. There's also the Siglec-8s are starting now on CSU, so we'll see where that lands us. There are c-Kit and wild-type therapies that are currently now being investigated, and there are also these are the more common ones that are being done right now. So it's an interesting area, but we still don't have another biologic at the present time, other than the omalizumab. So more to come in this area. There are also, this is just showing the treatment strategies for angioedema, because I want you to realize that we do have these different strategies of on-demand therapy to rapidly stop the attack, short-term prophylaxis, prevent attack when the patient would be exposed to a known trigger, maybe in some cases, obviously surgery or dental work might be a trigger for attacks in some patients, not all patients, and then long-term prophylaxis to decrease the frequency and severity of attacks. So you need to individualize the patient to determine what is most appropriate. If they have like no attacks or one attack a year, this may be sufficient. If you know that they have attacks when they undergo invasive medical procedures, then you should certainly pre-treat. And if they're having frequent attacks or having attacks that affect the airways, then you may consider using prophylactic therapies. These are some of the acute therapies. Again, the plasma-derived C1 inhibitor, there's a recombinant C1 inhibitor, and icalantide, which is an inhibitor of plasma kallikrein, and then icatibant, which is a BK2 receptor blocker. This is used probably about 80% of patients, but in younger children, we use obviously a lot of Bernstein, which is the C1 inhibitor that's approved for acute attacks. It's approved down to 6 months of age. Recombinant is approved in adolescents, probably around 12, 13 years of age, but works very well also as an acute treatment for HA attacks. Icalantide is effective, but it requires to be administered by a healthcare provider, so there is a possible history of anaphylaxis. We used to use these therapies, danazol, in higher doses before a procedure, or tranexamic acid, either before a procedure to prevent an attack, or on a regular daily basis, or tranexamic acid. But they have a lot of side effects that are present. We still have some patients who are on low doses of androgens, which are better tolerated, but they don't want to come off because they're not having side effects and they're well controlled. But for the most part, we've replaced these agents with the newer prophylactic therapies, either plasma-derived C1 inhibitor given IV or sub-Q. Most are getting sub-Q, but this has to be given every 3 to 4 days, so it's a little more burdensome. The alanidilimab is given every 2 weeks initially for the first 6 months, and with no attacks, every 4 weeks thereafter. And the newest on the block is Bernstein, which is an oral calcine inhibitor that is approved for ages 12 and above. And again, does have some side effects, but most patients tolerate it, although not all patients respond. The early trial showed about a 45% response, but when you actually select patients properly, and it can have an effect as high as 92% once you eliminate the non-responders. So it's sort of a not a it's a selection bias to that statistic. So I just want to conclude by saying that the phenotypes of CSU are quite heterogeneous. Although endotypes for CSU are emerging, there's still many yet to be identified. Investigations of these proteosomes and transcriptomes may provide better insight to pathomechanisms. There's data on this currently. Simple hives do go into remission. However, if you have CIndU with CSU, these patients have a more protracted clinical course and can be more challenging to treat. Novel therapies that target cytokines like mast cell receptors and biologic pathways that regulate B cell activity appear promising, as I've mentioned. And then, of course, we talked about HA. It's rare. Most patients isolated angioedema will respond to treatments recommended for CSU. Talking about the normal complement HAE is a different talk and a much more involved. Of course, it's easy to make the diagnosis of H1H2, but can be confused with acquired. Of course, the difference is that these will have a mutation in the SIRT2 gene, whereas the acquired will not. And HA therapies are significantly evolving for the treatment of these patients, where they're no longer having attacks and not having the burden of illness that they were having 15 years ago. So that's quite promising. So that ends my talk. I'll be happy.